We would also like to welcome our presenter for the day, Mr. Pankaj Bazaz, a final year MBBS student from RIMS Raichur. I would also like to welcome Dr. Shivkumar B. Lakkol, sir, Honorable President of IMA KSB, for his gracious presence today. I also take the privilege to welcome Dr. Karunakar, sir, Honorary State Secretary, Dr. Madhusudan, sir, past President of IMA KSB, Dr. Vijay Sarathi, sir, Honorary Treasurer, and Dr. Shubhrata, ma'am, IMA Coordinator. Now, I would like to call upon Krupa, IMA MSN Karnataka's National Council member, to recite the IMA prayer.
Thank you, Kruti. I hereby request all the dignitaries and the students to kindly repeat after me our IMA prayer. May everybody be happy.
Let everybody be happy.
May everybody be healthy.
May everybody be healthy.
May everybody be free from pain.
May everybody be free from pain.
May everybody be free from sorrow.
May everybody be free from sorrow.
May we be the healing cure.
May we be the healing cure.
Beyond every greed and lure.
Beyond every greed and fear.
Thank you.
Okay.
Thank you, Krupa. I now take the privilege to introduce you all to our moderator, Dr. Kumar Andi, sir, who is consultant endocrinologist and associate professor of pediatrics in MRMC Kalburgi. Sir has a huge list of achievements. To speak about his professional achievements, Sir has been a national executive member of Presidential Action Plan on Congenital Hypothyroidism in India for the year 2018 and 19. He has been a member of the committee to frame 2020 and 21 revised IAP guidelines on vitamin D supplementation and prevention of nutritional rickets in India. Sir is also an author in IAP textbook of pediatric endocrinology and IAP textbook of PICU protocols. Sir has also served as editorial member of Cape News, which is an official publication of Indian Society for Pediatric and Adolescent Endocrinology for the year 2018 and 20. We doctors are associated with God in India, proving the statement to be true. Under the leadership of Sir, 120 children got free treatment and lab tests at Basveshwara Hospital under CDIC program Gulbarga. Sir is associated with Seva Bharati, a voluntary organization which works for health and educational needs of people living in slums. Sir is also associated with Janaspandana, a live phone-in health program conducted every fortnightly by Doordarshana Kendra Gulbarga. Adding more feathers to the cap, Sir has attended numerous conferences and has given 18 guest lectures at various academic platforms across the country. Sir is also All India Joint Secretary of National Medicos Organization. Sir is Sanchalak of Manthala Kalburgi, which is an intellectual forum for healthcare workers. The list of achievements goes on, and a session would fall less to list all of them. To have such an eminent personality amongst us today to guide us is absolutely a privilege to all of us. A warm welcome to you, sir.
Thank you, Shruti Kulkarni, for those kind words of introduction. Thank you.
With the permission of moderator, let's begin the clinical piece.
Pooja.
Yeah.
Pooja?
Yes, sir. Yes,
yeah,
sir.
we need to finish by 9:30.
Yes, sir. We'll begin, sir.
We have one more meeting by 9:30. I am a Karnataka State branch. Huh? Keep it in mind.
Yes.
Just 1 minute. Shall I address, sir? Madhu sir, how are you, sir?
Yeah, sir. Fine. I request
Yes, sir.
to have few words of wisdom.
Yes. Can you hear me, sir?
Yeah, I can hear you. Please.
Good evening to all. In association with the IMA KSB Academic Committee and also IMA MSN, this is a second case presentation from academic wing. I really congratulate our chairperson Sanjana Tellaru madam and also the eminent supporter and guider of our IMA past president Madhusudan Karyagunar sir in this connection. and Secretary of IME KSB, Karunakar sir, Treasurer Vijay Sarathi, and also renowned speaker of today, Dr. Kumar Angdi, Associate Professor of MR Medical College, and he happened to be from our place also. And he being a moderator, he will give us very good input to our students, and also the case presenter Pampa Bajaj, and all the students, those who are attending this session regarding the topic of nephrotic syndrome, make use of it. And I request Mithun, convener of MSN, to motivate your students to participate in this for their benefit. So with these few words, I will wish you all the students best, and also I am very much thankful to the moderator, Dr. Kumar Angdi. Really, we are very much happy to have you, and we need good guidance to our students also. And once again, I thank you all the best. Thank you. Thank you.
Thank you, Lakul sir. With our moderator's permission, let's begin the case discussion.
Please go on. Please go ahead. Am I audible?
Yes, sir.
Yeah.
So is the screen visible?
Yes, yes.
Okay. Good evening, everybody. My name is Pamposh Bajaj. I am a fourth-year medical student in Raichur Institute of Medical Sciences, and today I'll be presenting a case of a 5-year-old male child from Manjalapur. The patient's informant is the mother. The reliability is good. The patient was admitted on the 31st of October 2022 and was examined on 2nd of November 2022. The patient presented with chief complaints of fever since 4 days, facial puffiness since 3 days, and swelling in both lower limbs since 3 days. History of presenting illness. Patient was apparent.
Hold on.
Yes, sir.
Please go to the previous slide.
Okay, sir.
Yeah. So, good evening to one and all present here. It is always so nice to interact with the young brains. So I'm very glad and I'm very thankful to the IMA for this opportunity. So, okay. Coming to the case proper. May I know how to pronounce your name, gentlemen?
Sir Pamposh.
Pamposh.
Yes, sir.
Okay. So when I say Pamposh, I will be addressing to all the students. Okay. So whenever, whatever we are discussing, just now Pamposh went, go to the previous slide. Yeah. This particulars of the patient is also called as preliminary data. After preliminary data, we go to the chief complaints. After chief complaints, we go to the history of presenting illness. After that, we go to past history, family history, birth history, etc., examination. What is the purpose of doing all this exercise? Or what is the learning objective today of this case presentation or this class? Why do we ask all these questions? Go to the next slide. So why are we asking these questions? What is the purpose? What is the objective? What is the learning point that we are supposed to learn here? Anybody can answer. Shruti can answer. Pooja can answer.
So the basic idea is to understand how to assess a patient when he or she is first brought to you as a doctor.
Correct.
And
hold on. So assessing. Assess and do what?
So as a doctor, it's your responsibility to pick out things from the patient's history and complaints to lead to a diagnosis to whatever the patient's problem is.
Yes, that is the key word. That is the golden word. Can you repeat once again that word?
Diagnosis.
Once again.
Diagnosis.
Loud.
Diagnosis.
Okay. So I made you repeat, in the sense I made all of you repeat this word called as diagnosis. The objective of today's class, or for that matter, the life of a clinician, is always to reach to the diagnosis. Your understanding? So the purpose of, or the learning objective is learning this art of making diagnosis. Okay, all the things that we are dealing with, right from age, right from sex, right from the address, residence, chief complaints, all of these things will take us towards diagnosis. Is that clear?
Yes, sir.
Yeah. So with this objective in the mind, let us come to this part of the case paper. Whatever is written in the case sheet, this what you are reading out, it is called as what, Pamposh?
Case sheet.
This is a scientific document called as case sheet. Everything written in the case sheet has an objective. This is not a novel or a fictional thing. Okay, the objective is to reach to the diagnosis. So at the end of chief complaints, there are certain objectives, irrespective of the case, irrespective of the system involved, irrespective of the subject we are dealing with. After this is clinical medicine. After the end of chief complaints, we should be able to achieve 3 objectives. Should I repeat? How many?
3 objectives.
After the end of chief complaints.
Yes.
The first objective is, which is the system involved. Should I repeat? Pomposh,
Yes.
can you repeat? Which is
The
the
system
system
involved.
involved.
Yes.
Number 2, is it acute, subacute, or of a chronic duration? Number 3, probable etiology in our case. Forget about nephrotic syndrome. I'm talking about pediatrics in general. After the end of chief complaint, we should be able to, number 1, pinpoint which is the system involved. Number 2, duration. Number 3, what could be the probable etiology of the disease. That we should be able to pinpoint. I will give you some examples, you will understand. A similar 5-year-old child, na?
Yes, sir.
Yeah, 5-year-old child comes to you with the history of fever. Okay, running nose. Okay, 3 days. Should I repeat? Fever, running nose, 3 days. Can you apply the principles? Which is the system involved?
Otorhinolaryngology.
Respiratory system. Upper respiratory,
Yes,
we can call
yes,
it as. Number 2, child has fever. So what could be the probable etiology? Infective or non-infective?
Infective.
Infective. Number 3, child is having these complaints since 3 days. So is it acute or subacute or chronic?
Acute.
So can you come out with the diagnosis? After reading the chief complaints, we are able to pinpoint that this child is having acute since 3 days, upper respiratory since only running nose, fever, so it is infection. So we are dealing with a case of acute upper respiratory tract infection. Is it clear?
Yes, sir.
Another example I'll give you, you will understand. Another same child, 5 years old, comes to you with the history of fever, say 8 to 10 days duration, fever, 8 to 10 days duration, cough with expectoration. You're getting it?
Yes, sir.
Yeah. So what could be the, apply these principles again? Fever. So it is
Infective.
infective. 8 to 10 days, acute, subacute, or chronic?
Subacute.
Subacute. Cough with expectoration, which is the system involved?
Lower respiratory tract.
Lower respiratory. What could be the probable diagnosis? Bacterial pneumonia, 8 to 10 days duration.
Yes.
Another example I'll give you, you will understand further. Same 5-year-old child comes with the history of, say, 3 to 4 weeks of fever, 3 weeks of cough, some weight loss. Okay, you're understanding?
Yes, sir. Yes, sir.
With expectoration. So
Yes.
can you apply again? So 3 to 4 weeks duration. Is it acute or chronic?
Chronic.
Chronic. Cough with expectoration, which is the system involved?
Lower respiratory tract.
Okay. Fever is there. So what could be the etiology?
Tubercular.
Infective etiology. Okay.
Infective.
It is an infective etiology. Because the duration is very chronic, we could be thinking of, what do you say? Tuberculosis.
Tubercular.
Can you understand
Yes, sir.
how a simple upper respiratory can be picked up after chief complaints? How a bacterial pneumonia can be, you are making diagnosis with just 3 to 4 words. Are you able to make diagnosis?
Yes, sir. Understood.
Yeah. So another example. So sorry, let us complete this. So another child, the third case was say 3 to 4 weeks of duration, cough, fever, expectoration. We are thinking of tuberculosis. Same cough, fever, and expectoration. 7 to 8 days, we make a diagnosis of bacterial pneumonia. Same cough and running nose and fever of 3 days duration, we make the diagnosis of upper respiratory tract infection. Are you understanding how important chief complaints are? How important history taking is? We are not even touching the child, but we have made a diagnosis. I'll give you another example. You'll understand further. A child, say 5 years, 3 years old child, comes with fever, 2 to 3 days duration, running nose, convulsions, and the child is in coma. What could be the, can you apply here? Fever, acute or chronic? Sorry,
Acute.
infective or non-infective?
Infective.
2 to 3 days duration, acute or chronic or subacute?
Acute.
Acute. Child was all right. Child has shown convulsions and almost in the coma within 3 days. What do you think? Which is the system involved?
Central nervous system.
Central nervous system. This is a case of acute infection of the central nervous system, which is coming and hitting the child like a thunderstorm. Child who was fine is almost flat now. This is how a typical viral infection of the central nervous system presents. Are you getting the point?
Yes, sir. Understood.
Another child comes to you with, say, same 3 to 4 years old child comes to you with fever of 8 to 10 days duration, headache, vomiting 2 to 3 days duration, today morning convulsions. So again, apply acute or subacute, 8 to 10 days.
Subacute.
Subacute. Fever, infective or non-infective?
Infective.
Infective. Vomiting, projectile vomiting, headache, convulsions. What do you think? Fever.
Meningoencephalitis.
Central nervous system involvement.
Yes, yes,
Probably
yes.
bacterial meningitis. Another case, you can just say 3 to 4 weeks of fever, headache, irritability, and now the child has come with projectile vomiting and convulsions. So this is third cases of a chronic infection of the CNS system. This could be tubercular meningitis.
Yes, sir.
You're understanding? We
Yes,
are just with simple 3-4 words in our chief complaints. We are making big diagnosis like viral meningoencephalitis or bacterial meningitis or tubercular meningitis or tubercular pneumonia. All these things. At which level we are making this diagnosis?
Chief
At the level of
chief
chief
complaints.
complaints. All right. So that is the importance of chief complaints and how you analyze the case. This is the approach that is needed as a clinician. You're understanding?
Yes, sir.
Another example I can give you. Fever, vomiting and loose motions, 3 days. So fever, is it infective or non-infective?
Infective.
Vomiting and loose motions, which is a system involved?
Gastrointestinal.
Okay. Acute, that is 3 days duration. Is it acute or chronic?
Acute.
What is the diagnosis now?
Diarrhea.
Oh, diarrhea is a complaint. What is the diagnosis? Acute, gastroenteritis.
Enteritis. Okay.
You're understanding?
Yes,
So
sir.
at the end of the chief complaints, you should be able to pinpoint which is the system involved, probable etiology with chronicity. Can we make out some sense of the chief complaints and come to some diagnosis? Mind you, at every level of the case paper, at every level of the case presentation or history taking, we should be after that magical word called as
Diagnosis.
diagnosis. Okay. Now let us apply here. We have 1 hour now. When should
Yes.
I stop? 9:30 I should stop, right?
Yes, sir.
Yeah, fine. So shall we apply here the same principles?
Yes, sir.
Go on.
Patient gives history of fever, so probably of infective origin.
Okay.
The duration is 3 to 4 days, so acute in onset.
Okay.
And there's history of facial puffiness and swelling in lower limbs.
Okay.
So one can suspect either a cardiovascular system involvement or an endocrine involvement or a renal involvement
Okay.
or malnutrition.
Okay. So now let us apply those principles that we have found. There is facial puffiness, right?
Yes, sir.
And lower limb edema. Both of them are there. So we are dealing with the case of you can say generalized edema at the end of chief complaints, or if you are using medical term, we can call it as anasalca is a presentation which we are having right now.
Yes,
So
sir.
when we have such kind of complaints, the case is wide open. As you told, it could be you're missing few things. It could be hepatic also. It could be renal also. It could be cardiac also. Okay.
Yes,
So the case is wide open now. In such cases, then we progress towards history of presenting illness. There, with this things in the background, with the approach, having that I'm dealing with the case of anasarca or generalized edema, we will go into the history of presenting illness. You're understanding how to analyze chief complaints in general?
Yes, sir. Understood.
Okay. So I hope all of you are following it. Okay, proceed. You understood the objectives to be achieved at chief complaints?
Yes, sir.
Yes. Chalo, proceed next. So, at the end of history of presenting illness, again, there are objectives to be achieved. Okay.
Yes, sir.
At the end of history of presenting illness, there are certain objectives to be achieved. What are they? Like in this case, if we don't know the etiology, then we will be analyzing the symptoms one by one and trying to get into the cause for the disease, which could be the etiology. Number one. More importantly, in history of presenting illness, at the end of chief complaints, we have had some diagnosis like acute gastroenteritis, acute respiratory infection, tuberculosis, or pneumonia, or encephalitis, or bacterial meningitis. Any diagnosis we would have made depending on the chief complaints. In the history of presenting illness, what diagnosis we had made at the end of chief complaints, keeping that diagnosis in the mind, we anticipate complications and ask leading questions. Very complicated sentence.
Yes, sir.
Okay, I'll explain. So, for example, now we are in history of presenting illness. I'm trying to explain you the objectives to be achieved. Like the objectives to be achieved in chief complaints, I told right now, just a while ago. Now, what are the objectives to be achieved after the end of history of presenting illness? They are, for example, you have made a diagnosis of acute gastroenteritis at the end of chief complaints. I'm giving an example. In history of presenting illness, you should anticipate the complications of acute GE. What is anticipation? When a child with gastroenteritis come, we expect some complication with this child. That is called as anticipating the complication and ask some leading questions to confirm those complications or rule out the complications. For example, if the child with acute gastroenteritis comes, what could be the complications? What are the complications you anticipate?
Dehydration.
Very good.
malnutrition,
Dehydration, hypovolemia, shock. Okay. Can the child with the acute gastroenteritis have dyselectrolytemia?
Yes, sir.
Yeah. So can you ask mother, does your child has dyselectrolytemia?
No, sir.
No. But these are the complications you know. Okay. What are the complications of hypovolemia and shock?
Multi-organ dysfunction.
Multi-organ dysfunction. Which is the first organ to be affected? Most common?
Kidneys.
Renal. Exactly. So with this background in the mind, we will proceed to the history of presenting illness. For example, if the child comes with gastroenteritis, there could be pre-renal AKI. You understand what is pre-renal AKI?
Yes, sir.
Pre-renal failure, which is the cause for the renal failure is not kidney but shock.
Yes.
Okay,
yes.
so you will ask mother. How will you ask the mother? You will ask her with some leading questions like, is your child passing urine adequately? What is the volume of the urine pass? What is the frequency of the urine pass? If the frequency of the urine is reduced, or if the volume is reduced, what we call it as oliguria. If there is completely absence of the urine output, we call it as anuria. Okay, so when you ask this question, kid, is your child in pre-renal AKI? Mother will not understand. So you will be asking in her language, asking her about the urine output. You are going to diagnose shock in the child with acute gastroenteritis. Okay, child could be having dyselectrolytemia, like hypokalemia. Can the child have hypokalemia with acute GE? Potassium loss can be there. The child can have hypokalemia. So how will you ask the mother? Hypokalemia presents with paralysis. Okay, is your child able to move your limbs or not? Okay, child could have sodium problems, and child can have hyponatremia or etc. Hyponatremia and all. They can present with convulsions. Did the child throw convulsion? These are complications you anticipate and ask leading questions. Now, if the answers to these questions are yes, then the diagnosis will be acute gastroenteritis with dehydration, with hypovolemic shock, with prerenal AKI, with hypokalemia and hypernatremia, whatever it is.
Yes, sir. Understood.
So diagnosis is expanding like that. You're understanding?
Yes,
With
sir.
these principles, with these objectives in the mind, let us proceed to your case. Let us see what we can learn from this case.
Yes, sir.
Proceed. You are understanding background of the history of presenting illness?
Yes, sir. Yes, sir.
Yeah, proceed.
Patient was apparently normal 4 days back when the informant noticed fever. It was sudden in onset and progressive. It was of high grade, associated with chills and rigors, aggravating through the night with no relieving factors. Informant also complains of facial puffiness, which is also sudden in onset. First appeared around the eyes, then all over the face. There are no aggravating or relieving factors. Facial puffiness is followed by upper and lower limb swelling, which is again sudden in onset and of mild type. There is no diurnal variation. It started in the ankle and has ascended up to the mid-thigh. There's associated decreased urine output, which was initially 4 to 5 times per day and has decreased now to 2 to 3 times per day. The urine is yellow in color, frothy, non-bloodstained, non-foul smelling. There is no history of abdominal distension, genital edema, no yellowish discoloration, no altered sensorium, no history of breathlessness, no rash, no burning micturition. There's no history of loss of appetite or weight loss, and there's no history of difficulty in feeding. There's no history of chest pain, palpitations, or breathlessness on exertion. There's no history of recent drug intake, and no history of swelling in the neck or heat or cold intolerance.
Okay. So now can you analyze them? Why you have asked these questions and how you will analyze? Now, in this case, we do not have, the case is wide open. Okay, we have to zero down to one of the systems,
Yes.
which we should do in the chief complaints, but in this case, we could not do. Okay, so can we pinpoint the system involved with the history of presenting illness?
Yes, sir.
Yeah, please go ahead. Explain
since-
which system could be involved here.
Yes, sir. Since the informant has given history of facial puffiness first, I was suspecting a probable renal etiology.
Okay.
And patient has given history of fever, which I could not really explain, but I was suspecting an infective cause, but I could not really explain the cause of the fever.
Okay.
Since there is history of facial puffiness, I was suspecting a renal etiology, and then the patient is also the informant is also given history of decrease in urine output, which can either suggest a pre-renal or renal failure, acute kidney injury. Then to rule out other systems, I asked history of.
No. Don't go into other systems.
Yes, sir.
Before going to other systems, with edema, with this history only, we can get into the different systems can be ruled out. How will
Yes,
the
sir.
edema be if it's a case of typical renal edema? Forget about this case. Ideally, how does a renal edema present?
First in the face and then in the lower limb and then progressively generalized.
Okay, so typical renal edema presents with periorbital edema, that is swelling around the eyes. Then this edema progresses towards the other parts of the body. This is number 1 point, which is saying that this could be renal edema, which
Yes.
is another important point which will differentiate between renal and non-renal edemas. One is where the site of onset is one. What are the
Yes.
other? What is another thing which will say renal or non-renal? Pompesh?
Pitting, non-pitting. Hello. Pitting, non-pitting.
No. That is in the examination, no?
Yes, sir.
Pitting and non-pitting, you do examination. We are in history.
I don't know,
Okay.
sir.
Yeah. There are some answers I'm getting in the chat box. The answer to this question is typical renal edema presents with site being periorbital edema. Number two, very important point is diurnal variation in the edema. Okay, if it is a renal edema, the puffiness around the face or the swelling will be more in the morning. As the day progresses, what happens to the edema? It reduces. So this is how a renal edema presents. Sight, eyes, as the day progresses, edema decreases. If the cause was say cardiac, which will be the site of the onset? It will be lower limb which will be involved first. And as the day progresses, what happens to the edema in the cardiac edema?
Increases.
It will increase. Okay. If it is, say, liver pathology, liver edema, the edema presents with ascites first. That is in the abdomen. You're understanding?
Yes, sir.
Okay. And it will be generalized edema. So with the site where the edema is appearing first, number one. Number two, what is happening to the diurnal variation? If there is more in the morning, gradually it reduces as the day progresses and almost nil in the evening. And that takes us towards renal edema. Whereas if the site of the onset is in the lower limb and the edema increases as the day progresses, then that is cardiac edema. Okay.
Yes,
so, did you ask this question?
So I had asked for diurnal variation of facial puffiness.
Did you get the answer?
Yes, sir. There was no diurnal variation according
because I don't see you mentioning in your presentation.
Yes, I've mentioned it, sir.
You have mentioned?
Yes, sir.
Okay. Facial puffiness, lower limb. There is no diurnal variation. Okay, fine. I can see that. So
Yes,
there is no diurnal variation. Fine. So this is one point which is taking away from the renal system, but definitely onset in the eyes will pinpoint towards renal system. All right. Okay. Can you further go ahead with so if it is renal system, which is a renal disease which can cause edema?
So nephrotic syndrome.
Okay. Can nephritic syndrome also have edema?
Yes, sir.
Yes. So how do you differentiate in the history? Now we know that with some clues, this could be a renal edema. In the history, can we differentiate between nephritic and nephrotic syndrome?
Yes, sir.
Yeah.
So patient could probably give a history of sore throat or a skin infection.
That is in the past history, no?
Yes, sir. As in to
history of presenting illness.
So urine color, sir.
Very good.
So nephritic will have a cola colored urine, sir.
Very good. Okay, fine. So I will tell the answer. The answer to this question is the nephrotic syndrome. It presents more with the edema, whereas nephritic syndrome presents with decreased urine output or oliguria more. Okay. Renal failure is the presentation. Hypertension is the presentation in nephritic syndrome, whereas nephrotic will present with more of proteinuria and edema in that sense. There could be overlapping, but in general, this is how it is progressing. Okay. Proceed further. This no histories you have asked, no?
Yes, sir.
Can you tell?
Yes, sir. There's no history of abdominal distension or genital edema and no yellowish discoloration. No altered.
Why you have asked, you should tell answer.
Yes, sir. So abdominal distension to rule out any hepatic causes. So yellowish discoloration for any jaundice.
Okay.
So altered sensorium to rule out any uremic or any hepatic encephalopathies possible.
Okay. Okay.
Go on. Sir, no rash or burning micturition again to rule out any nephritic as in infectious causes. Then
which renal disease presents with rash?
So as in there can be a history of skin infections in post-streptococcal glomerulonephritis. So patient can have
that should come rash. That should come in
past
history of presenting illness or past history.
patient can have a concurrent infection as
No.
well. after
So
infection.
again, there needs to be some clarity on the concept. Okay. So what is the duration between the onset of the nephritic syndrome, if it is post-streptococcal, from the duration of the onset of pharyngitis or pyoderma, that is skin infection?
So,
Did you understand the question?
yes. So about 1 week, so 1 to 2 weeks.
You can't say about.
So 1 to
Okay.
2 weeks.
Okay, so if the sore throat, it is 2 weeks. Skin infection, it is 6 weeks. 4 to 6 weeks is the duration. Okay, so this history of skin lesion in renal case should come in
Past history.
past history. Okay, proceed.
So there's no history of loss of appetite or weight loss, and there's no history of difficulty in feeding. So I asked loss of appetite or weight loss to rule out malnutrition or malnutrition related
Okay,
renal loss, protein losses that can lead to edema. And there's no history of chest pain, palpitations, breathlessness, and exhaustion to rule out any cardiac causes. There's no history of recent drug intake to rule out any if the patient is on any chronic medications already, or if the patient has taken paracetamol, because the patient can have hepatic failure due to paracetamol intake toxicity.
Okay.
And there's no history of swelling in the neck or heat intolerance or cold intolerance to rule out any thyroid dysfunction.
okay.
Yeah.
ठीक है. Proceed. So with the history of presenting illness, we think that this is a renal edema. This could be nephrotic or nephritic also. We are not very sure about it. More likely to be nephrotic.
Yes, sir.
What is very important part in the history of presenting illness you are missing in a child who presents with renal edema? Anybody? Say if the case could be nephritic syndrome. There is a mixture, right? Oliguria is not a presentation in nephrotic syndrome. Fever is not a presentation in nephrotic syndrome. By chance, if this child had nephritic syndrome, there is one complication which you are missing. I said your history of presenting illness is more of anticipating complication and asking leading questions.
Yes, sir.
So which is one leading question? Yes, there is some Darshan. Yam Darshan is answering that. Okay. Pooja Patil is also answered it. That is hypertension. So we can't ask hypertension, no Darshan. So can you unmute and ask the question? Can they unmute? So how will
Hello.
you ask hypertension?
Dizziness, sir.
Okay,
Headache.
very good. And
Vomiting.
okay. Fine. So what is hypertensive encephalopathy? How does it present? This is how it presents, like visual disturbances, headache, dizziness, vomiting, or sometimes convulsions. And sometimes if this had led to the bleed, there could be hemiparesis also, in the sense weakness also. So hypertensive encephalopathy is a must to be ruled out in a case with renal edema. Okay, because nephritic syndrome presents with hypertension. In a child who comes with nephritic syndrome, what is one thing which we are worried in managing this child? Nephritic syndrome is the treatment is just supportive. It is a self-limiting disease. Yes or no?
Yes.
It is immunologically mediated. So self-limiting, no specific treatment. Okay.
Yes, sir.
Unlike nephrotic syndrome. In nephritic syndrome, what we are more worried in children with nephritic syndrome is the hypertension with which they present. Okay. And hypertensive crisis. So definitely we have to rule out hypertensive emergencies like hypertensive encephalopathy or just even symptoms of hypertension to take into consideration when we are dealing with a child with renal edema. Okay, because children with nephritic syndrome can present with edema also. Okay. And the other thing, I don't know if you have added, have you ruled out cola color in urine?
So I asked for a color of urine. So
Have you
color was
written?
yellow. Yes, sir.
Yellow
was
color. Okay.
Yes,
No
sir.
high color, you should say. Fine. Okay. Proceed. You are understanding?
Yes, sir. Yes, sir.
So looks more likely to be a nephrotic syndrome case, and we have ruled out other system involvement like cardiac and liver, and we have ruled out hypertensive emergencies also in our history of presenting illness as the complications. You understood?
Yes,
After the end of chief complaints and history of presenting illness, at least now we should be having which is the system involved and what are the complications that have happened secondary to the primary disease that we have diagnosed. In this case, renal edema, mostly nephrotic and non-nephritic, no hypertensive encephalopathy, no complications of the nephrotic syndromes have been seen in this child with this history. Is that clear?
Yes, sir.
Okay. So this approach, you should apply this approach to all the systems, not only renal or nephrotic. Okay.
Yes, sir.
Proceed further.
Past history. Patient has history of similar complaints of facial puffiness, abdominal distension, lower limb edema since he was 8 months age. Patient has had 9 episodes and 3 episodes in the last 12 months. Patient has been admitted in the hospital following each episode for a duration of 5 to 7 days, and patient recovered following receiving treatment.
Very significant. Okay. What is this history suggesting of?
Relapsing
Compost?
condition.
Relapse.
Relapsing condition.
So now is it more clear which
Yes,
is
sir.
the diagnosis that we are dealing with? Is it
Yes, sir.
nephritic or nephrotic?
Nephrotic, sir.
Nephrotic syndrome. Okay. So can now with this history make the diagnosis of whether he's a frequent relapser or non-frequent relapser?
Sir, since this is the 4th episode in the last 12 months, patient can be a frequent relapser, sir.
Frequent relapsing. Okay. Fine. So why is it important?
So we have to check for any steroid dependence or steroid resistance or in such patients.
Steroid dependent, steroid resistant, frequent relapsing. This is one of the indications to do renal biopsy.
Biopsy, sir. Yes, sir.
Okay. So does age of the onset of the disease speak anything?
Sir, nephrotic usually starts between the age of 2 to 6.
2 years to 6 years. So
Yes,
the age of the onset is very early.
Yes, sir.
Okay. So what is the most common type of nephrotic syndrome in children?
Minimal change.
Minimal change. Does this history tell us that this could be a minimal change disease?
No, sir.
Unlikely to be. Okay.
Yes.
Because early onset and so many relapses, these are all the pointers which are taking us towards significant disease, not a
Yes.
minimal change disease. Okay. Very good. Proceed.
Antenatal history.
We can
First,
anything significant here?
no, sir.
Due to want of time, we can proceed further.
Okay.
Okay.
So natal history is no history of NICU admission. Birth weight was 2.8 kgs. Nothing significant.
Okay. Here, hold on, gentlemen.
Yes,
Go
sir.
back. Few things we cannot miss. Did this baby cry immediately after birth?
Yes, sir.
Where is it?
So I missed that. I missed that.
Okay. Baby cried immediately.
Yes, yes.
Term gestation,
Yes, sir.
hospital delivery,
Yes,
normal delivery,
yes, sir.
birth weight
The 2.8
is
kgs.
appropriate for gestation.
Yes, sir.
So these are few things we don't, done by obstetrician and gynecologist is not necessary.
Okay, sir.
If you do your MBBS and if you are posted in rural posting, you are not an obstetrician, but you
Yes,
can
sir.
conduct deliveries.
Yes, sir.
So that point is not needed. What is more important is it institutional delivery, that is hospital delivery, hospital born or home delivery. Number 2, did the baby cry immediately after birth or not? We have to rule out in every child where you're taking birth history. Okay. Not necessarily that all the deliveries needs to be done by obstetricians.
Yes, sir.
Okay. Proceed.
neonatal history, so there's nothing significant. So breastfeeding was initiated immediately after birth. Frequency was on demand. Passage of urine and stools is in 24 hours.
So what we call it as postnatal history, not neonatal history. Okay. Immediately after birth is postnatal.
Yes, sir.
Okay. Proceed.
Immunizations, the patient has been immunized up to date, sir. So it's,
Birth, immunization. Okay. Fine. Next.
developmental history, sir. Patient is developed for age.
Appropriate.
Yes, sir. Age appropriate.
Okay. Then
Dietary history, sir.
diet. Okay.
Socioeconomic, sir.
Okay.
Uh,
Fine. Which class do they fall into?
Upper lower class. sir,
Upper,
according
lower.
to
According to Kupusamis classification. So this is very important, the way Pompesh has presented the case, the headings of the history is very important. Many a time when we are in the examination, examining you guys, you will be just copy pasting what is written in the medicine case paper. That personal history, no smoking, mixed diet, bowel and bladder normal, sleep addict. That is not pediatrics. Pediatrics case sheet should have these headings. That is chief complaints, history of presenting illness, past history. Family is missing, no? Pompesh? Hello? Hello? Am I audible?
Yes, sir, you're audible. Pampush, can you unmute your mic? You're not audible.
No, what about answer?
1 second. I think they should have got disconnected. We'll just wait for a second. See, yeah, I think it's back.
Okay. Can you unmute?
Yes, sir.
Yeah.
Yes, sir. Yes, sir.
Can you share your screen?
Yes, sir.
Did you mention the family history?
Yes, sir. I said there was nothing significant in the family history, sir. I did not mention it separately, sir.
No. You can't do that. Go back. Okay, go back. Go back. Hindu go mundalla. Hinde. Innu hinde. Past history. Admele, family history is important.
Okay, sir.
After this past history, we should get family history here. Okay,
Yes,
you will
sir.
not be pardoned if you do such mistakes. Okay, there are many diseases where family history is very important. Say if you're dealing with a child with thalassemia, if you're dealing with a child who comes with global developmental delay. Yeah? Can they have
Yes,
family
sir. I had
history?
asked. Yes,
You
I had
can
asked for
ask.
past.
I don't know you have asked or not. What you have told in the exam is important.
Yes, sir.
What you have written in the case paper is important. So no, this is all learning. Don't
Yes, sir.
take it as the otherwise. What I'm saying is things cannot be missed like this. After past history, you should have birth history followed by past history admele family history, then birth history admele immunization history admele developmental history,
Developmental.
diet, socioeconomic. Because pediatrics is special, pediatrics is different. If what is the importance of immunization history in this child? You wouldn't be pardoned if you have not taken immunization history in this child. You know why? If this child had not received, say, H influenza, if this child has not received pneumococcal vaccine, could that be determinant to this child as compared to that of another child who didn't have nephrotic syndrome?
Yes, sir.
Yes. How?
So patient is more prone to infections in such cases. Patient is already.
Which type of infections? Particularly, I'm asking meningococcal, pneumococcal. These are the special vaccines which should be given to the high-risk children. This child is high risk. These children are at risk for infections with encapsulated organisms like pneumococcal, meningococcal, and all. That's why. So pediatrics is special. We can't miss anything in this pro forma, in this case sheet. As I told, it is scientific document, and it helps us in taking care of the complications, taking care of the diagnosis, taking care of the treatment if none of them are missed. Is it clear?
Yes, sir.
Okay. No part of this case paper can be skipped, whether it is relevant or irrelevant. Proceed. General examination.
So this is a 5-year-old boy. Patient was conscious, alert, oriented to time, place, and person. The child was playful and cooperative to examination.
Hold.
The vitals.
I have a small submission here. What is this orientation to the time called as? What is this orientation to the place called as? What is orientation to the person called as? A 5-year, this orientation depends upon the age. 5-year child can be oriented to the place. He can say that I am in the school, I am in the hospital, I am at my home, I am in somebody else's home, I am in park. This is orientation towards time, place. Person, she is my mom, she is my dad, he is my dad. This is orientation towards person. Can a 5-year-old child be oriented towards time, gentlemen? 5 वर्ष मंगोगे 5 साल के बच्चे को आप पूछ सकते हो क्या समय क्या हुआ है?
No, sir.
नहीं ना? Okay, so corrections doesn't matter. This is teaching, not examination. So when you ask orientation, again, pediatrics is special. Pediatrics is different as compared to that of adult. All adults, you expect them to be oriented to time. We can't expect a neonate to be oriented towards place and person or time. This orientation is age dependent, and pediatrics has got a wide range right from newborn till 18 years. Okay, depending on the age, we need to ask comment in the exams. Okay, in fact, you have to ask. It's not just commenting, and the same thing you should be writing in your examination. Okay, proceed.
So vitals, pulse rate is 72 beats per minute. It is regularly regular, normal in volume and character. Respiratory rate is 12 cycles per minute. Predominantly abdominal thoracic, and temperature was 36.8 degrees Celsius. Again,
what I was afraid of, the same mistakes have been committed. Go back. Vitals are again age dependent. What is the normal heart rate in a newborn? What is the normal heart rate in a 5-year-old child? 70 would be bradycardia for a 5-year-old child. 12 is a bradypnea, that is respiratory rate is low. For it's again age dependent. So be careful when did you examine the don't answer to this question. Just think, did you count the respiratory cycles in this child for 1 minute and have you written? Did you count the pulse for 1 minute and have you written? And very important in this case is, what is the blood pressure in the child?
Yes, sir.
Okay, and all of you who are here, it's not only about Pamposh. We all tend to make such mistakes in pediatrics. Pediatrics is special, I repeat, not difficult. Pediatrics is challenging though, but it is beautiful and very special. Again, in this case, why BP is important?
Hypertension would suggest of nephritis.
Sorry?
Hypertension would.
Yeah, hypertensive crisis. Okay. Again, when you measure BP in children, you can you have a 120 by 80 kind of a BP here? 5-year-old child 120 by 80 is
hypertension.
Hypertension. Then how do we comment about BP in these children?
Some more than 100 by
percentiles.
60.
Okay. What is which percentile is the child falling in? That is how we should comment on the BP. Temperature is okay, but respiratory rate, pulse, we should have a normal range for the age. Okay. BP, percentile, which is dependent on the height also of the child. Okay, we have percentile childs for the BP of the child. Okay, so is the pediatric, is it beautiful? Is it different and special? Or is it difficult? on the network problem against the competition.
No, sir. No, sir. I can hear you, sir.
I didn't get an answer. So it is
Sir, it's a bit
special.
difficult,
Okay.
sir.
It's beautiful. Okay. Proceed. So your understanding, vitals needs to be
Yes, sir. Yes, sir.
age specific ranges you should have. Proceed.
The head-to-toe examination.
Yeah.
Head of the patient is erect. The hair is black, lossless, non-pluckable. Pallor is present. Icterus is there's no icterus. There's periorbital edema. There are no deformities in the nose. There are no discharges from the nose. The philtrum is present and normal. Pallor is present in the oral cavity. There are no external deformities in the ear. There is no low set ears.
Hold on,
No discharge
hold on,
coming
hold
from
on.
the ears.
Hold on. So after the end of, we will go one by one.
Okay, sir.
So head is erect.
Yes, sir.
What is it? Head.
What's it?
How do you comment about the head in the general physical examination in children?
Support.
What is the
Portions.
size and what is the shape of the head? Okay. Head to toe examination, you can comment that head is appearing normal, small or large. Shape of the child appears normal or abnormal. If it is abnormal, then we are in the examination. So we should be able to comment about the abnormality. Is it dolichocephaly? Is it brachycephaly? Which type of abnormality of the head we are seeing? Head is erect. What do you mean head being erect?
Posture, sir.
Corrections. Okay.
Okay, sir.
In head, what we should say?
Size of the head.
Size of the head. Apparently,
Shape of
it
the head.
appears to be a normal sized head. Or if you have seen a CP child, you will see very small, just very small head can be made out. Okay, like that.
Yes.
All right. Proceed. In the eyes, you are saying no. In the head, you are saying hair is black. We should use dark is the right term to be used. Dark hair, lusterless, non-pluckable. Can I pluck your hair?
No, sir.
Anybody can pluck anybody's hair, man. Hair is not non-pluckable. It is easily pluckable. What is it?
Easily pluckable.
Okay.
Not easily pluckable.
Hair is not easily pluckable. What is easily pluckable and not easily pluckable? If you hold the hair and pluck like this, anybody's hair could be plucked. Does that mean that I am suffering from PEM? No.
No,
Easy
sir.
pluckability is just move your fingers in the hair like this. Can you see
Yes.
it? And just pull with the power of the fingers approximating each other. This is if the hairs are plucked, that is called as easy pluckability. You understanding?
Yes.
That is
Yes, sir.
easily pluckable hair. Then eyes, you are saying
Yes.
pallor is noted, icterus is absent. What do you mean by this?
Oh, sir, there's no yellowish discoloration in the sclera.
Sorry, there is no relation between
There's-
icterus and pallor.
I mean, sir, it's just a finding.
It's just
There
a
is
mention
no.
case sheet.
No, sir.
No, gentlemen. When you say eyes, there is pallor. You
Yes,
have
sir.
to look into the eyes. If you can get to know, do we have a cause for the anemia? What do I mean by that? If the child is having the eyes are pale, it means anemia. If eyes are yellow, it means what?
Jaundice.
Jaundice. Can there be some anemias which can cause jaundice? If there is
Hemolytic
hemolysis,
anemias. Yes, sir.
okay, there is a relation in why you have asked it. Again, as
Yes,
I
sir.
repeat, this is a case sheet and it's a scientific document with a reason. And one thing which is missing in the general examination is when you say that the child has got pallor in the eyes and icterus is absent, you should definitely mention the signs of vitamin A deficiency. If the child is having pallor and vitamin A deficiency signs like white hot spots or
White hot
what
spots.
are the eye signs of vitamin A
Conjunctival
deficiency,
sepsis, corneal
the
sepsis.
diagnosis of the anemia is going to be nutritional anemia. That is anemia due to decreased production. Okay, if the child is having pallor and icterus, that means the cause of the anemia is anemia due to excessive destruction. You know the classification of anemia? Increased destruction, decreased production, excessive blood loss. These are the causes of anemia which can be seen and made out diagnosis could be made by just simple physical examination. If the child is pale, look at the sclera. If the conjunctiva is pale, the sclera has icterus, it means the diagnosis is hemolytic anemia. If the conjunctiva is pale and sclera has got cornea has some vitamin A deficiency signs, the diagnosis of anemia is nutritional anemia. You're getting the points?
Understood.
So this is general physical examination. Okay, proceed. Some irrelevant important points which needs additions and corrections. Okay,
Yes, sir.
proceed.
So next source of there are no engorged veins, no lymphadenopathy, and no swelling in the neck.
Okay.
The shape of the chest is normal. The shape of the abdomen is normal, and there's no distension. There's no scarring or on the chest or the abdomen. There are no deformities in the upper or lower limbs, no nail changes, and there's no.
Okay, we are overshooting the time now. Tell me when I should stop. Okay.
Sir, you have 10 minutes, sir. We have next meeting scheduled. All over.
Yeah, fine. Go ahead with the systemic examination. Systemic examination, Gopal. Which system
yes,
you
yes.
want to examine?
So, upper abdomen.
Per abdomen. Okay.
Yes. So on inspection, the shape of the abdomen is normal or scaphoid. There's no distension, no dilatation of veins. The umbilicus is inverted and vertical. No visible pulsations and no fullness in the flanks.
So what should be the aim in the abdominal examination in a child with nephrotic syndrome? We should be able to diagnose if there is ascites. So could you find?
No, sir.
Huh? Percussion? Is it fluid
No,
thrill?
sir. No, sir.
No. Fluid thrill is absent. You're happy with it, or you want to proceed further with some other examination?
Sir, we can if fluid thrill is absent. Fluid thrill is only done for a large amount of fluid, so
Massive ascites.
Yes, sir. Massive ascites.
Okay, moderate ascites can be made out by which sign?
So shifting dullness, sir, or puddle sign, sir.
One is shifting dullness. Second is
Puddle sign, sir.
Before that.
So puddle
You
sign,
know
sir.
horseshoe shape. You know horseshoe shape dullness.
Yes, sir. It's a horseshoe dullness.
So minimal ascites is puddle sign, followed by horseshoe shape dullness, then shifting dullness, and lastly fluid thrill can be elicited in massive ascites. So that is not there. Proceed further. Other systems are normal.
All other systems are normal, sir.
Okay. With this history and examination, can you come to it? Yeah, please go ahead. Provisional diagnosis.
So 5-year-old male child presenting with complaints of fever, facial puffiness, swelling of lower limbs, and decreased urine output. On examination, patients found to have pallor, periorbital edema, which is the pitting type, and lower limb edema, which is the pitting type. Patient also has poor variant and stunted growth. Based on history given and findings in examination, the most probable diagnosis is a relapse of nephrotic syndrome, triggered probably due to severe malnutrition.
Okay, so these words you have to be careful in medicine. We can't give this as provisional diagnosis. We can say that I am summarizing the case. 5 years age cannot be a provisional diagnosis. Male cannot be a provisional diagnosis. The heading that you have written, it should be summary of the case, not provisional diagnosis. Provisional diagnosis is nephrotic syndrome. Maybe you can say it as a relapsed case of nephrotic syndrome. Agree.
That's
okay. Very close differential. You can keep it as nephritic also.
Yes.
Okay. Investigations. What do you want to do to rule out nephrotic or nephritic?
Investigations. Sir, we can first.
I'm happy with your diagnosis.
We can check the blood pressure of the patient, sir, to differentiate.
That is not investigation. That is examination. We have done that. Investigations now. Now we have, what is the importance of investigation? We have some provisional diagnosis with some differential. Provisional is working diagnosis. Provisional, it could be nephrotic syndrome with relapse. Differential, we can keep it as nephritic also. We have to confirm it with investigations. You'll ask for urine routine microscopy.
So serum estimation, so serum protein
Blood
estimation.
estimation. Urine olaga, you should see for proteinuria. Is it
Yes, sir.
nephrotic range or
Proteinuria,
nephrotic range?
hematuria, sir.
Okay. Blood, you want to do something
Sir,
apart from albumin?
sir,
Hypoalbuminemia,
lipid.
lipid profile. Okay. Dyslipidemia has to be taken into consideration.
Yes,
And if you are suspecting nephritic, we should go for complement and other levels. With these investigations, we can have a diagnosis. If it is nephritic syndrome, we should treat supportively with in terms of if there is hypertension, antihypertensive medications and other things which are just supportive management. Whereas if
Yes,
it
sir.
comes to the nephrotic syndrome, we should go with steroids.
Prednisolone.
In this case, this child warrants renal biopsy. Have they planned a renal biopsy here?
Yes, sir. Yes, sir.
It has been done.
So renal biopsy has been done, sir. So it was
Diagnosis has been established.
minimal change, sir. No, sir, minimal change.
Minimal. Okay, fine. All right. Very well done, Ambesh. Thank you so much. Thank you so much for patient listening. I'm very glad to meet so many young brains. I don't know. I assume this could be of some use to you people. Thank you so much. I thank IMA for giving me this opportunity to interact such young brains. Thanks a lot. Thanks a lot to all the office bearers. Thanks to my dear Akka, Dr. Sanjana Madam. Thank you so much.
Thank you, sir. We are now open for Q&A sessions. If anyone has any queries, you could raise your hand or put your questions in the chat box.
I think we are running short of time. I will just text my email. You can, or my number also. You can message your queries to the mail.
Yes, sir. And
Sure, sir. Thank you so much.
the same, I'll be sharing it in our
This is my
Yes,
email
sir.
ID.
group also, sir.
Thank you, sir. We'll put
Please
up the same in
off
the
the
WhatsApp.
screen share.
Thank you, Madhusudan sir. Thank you, Lakkol sir. Thank you, Yoganand Reddy sir. It's so nice to meet you people on this platform. Thank you.
Thank you, sir. It was indeed a very comprehensive clinical case discussion. I convey my heartfelt gratitude to Dr. Kumar Amdi sir for taking time out from his busy schedule and guiding us through the discussion. I also thank our presenter for his well-prepared case presentation, which aided our learning. I thank all the attendees of the session, without whom today's session wouldn't be possible. I also show my gratitude towards Dr. Arjun Singh sir, Chairman of IMA MS in Karnataka, who was constantly been supporting and encouraging the team of IMA MS in Karnataka through all its ventures. I would like to call upon Mithun sir to convey vote of thanks to all other dignitaries present amongst us today.
Thank you, Kruti. So thank you so much. Indeed, it was a very great interactive session. I'm sure the virtual joining students are really it will be shared in a YouTube channel also, sir. And the mail ID and the phone number. Thank you. And something that I would convey my greetings to Pooja, Vishnu, Chaturya, and Manona for taking their time and making sure, also Gaurav, to making sure that it reaches to everyone. I thank to all the IMA KSB office bearers, IMA and IMA subcommittee, and special thanks to Sajana for making it happen. Thank you one and all.
Hello, John.
Yes, madam. Yes, madam. Off, madam.
Log out ಆಗ್ಬೋದಾ? Kumar, I hope you students have a good session with him. Anything, if you want, you can call him or message him. He will help you in any way also. Okay.
Yes, ma'am.
Can I log out, madam?
Ma'am, thank you so much for arranging the session, ma'am, and being a supportive.
You want any other session
partner.
next Friday or no? Just I want any topic you want.
Madam, we'll start the other meeting.
Ma'am, good evening.
You message me later on. Okay.
Yes, ma'am.
Yes,
Thank you,
ma'am, yes.
sir. We'll conclude the session and thank you for this great session, sir.